Okay. Good morning. My name is Maxine McCarthy, and I'm a social worker at the ISABELLA Geriatric Center in New York. I started out as a CNA, did CNA work for 9 years, and through the SCIU Training and Upgrading Fund, I went back to school, became a social worker, BSW, because I wanted to do more, and now I'm in my last couple of weeks of the master's program at Lehman College. So, and this is gonna be, I'm going into my 4th year as a social worker again at ISABELLA Geriatric Center.
So she's going to give us some perspective of, line staff and alternatives to pharmacological interventions. And we're going to sort of have a freewheeling conversation because I think there's a lot of sort of a cross-section of information up on this panel. And I'm going to facilitate this. But I have one question that I really, Dr. Evans, you mentioned the hammer and the nail, but what, given how dangerous these drugs are, why do doctors prescribe them?
It's really illogical, and moreover, the idea that people who presumably deal with facts and data, that they would do things that are so illogical, it doesn't really make a lot of sense. What I would say to you is that if you think about the most important decisions you've made in your life, ask yourself, was this a decision based on cold, hard facts, or was it based on feelings? And I think that, if you think about where you went to school, who you married, what car you bought, and so forth, ultimately, and certainly if it was a tie, if there was some just question about which way to go, you go with your gut, okay? And I guess what I would say is, the culture of medicine is really, it's fairly hidebound in terms of tradition and doing things a certain way. That's number one. Number two, and so, I mean, it really, I guess to put it another way, the nail that sticks out gets pounded down, okay? And so, if you want to stand out among all of your peers in your workplace and so forth and be different all the time, that's not always going to be perceived as better or helpful, or you pay a price for that, I guess is what I'm saying. And even if you truly believe all the things we're talking about, I mean, this past week, I was fired by somebody whom I love and who loves me, okay, as their doctor and this is a nursing home where I've been the medical director for 15 years, because the director of nursing and the assistant director of nursing basically told them repeatedly, we're gonna have to kick you out or your aunt out if you don't take a medicine, and this doctor's not willing to give you that, so you have to change doctors. And actually, there's only one doctor that'll do that, so you have to have this doctor. And I mean, I really struggled morally with whether I should resign as the medical director, but I have other patients there that that I love, that I've taken care of for 15 years, and I don't want to punish them or punish myself by not, So I mean, I guess what I would say is it's a culture of conformity. I don't want to take too much time, I'm sorry, but the other thing you have to keep in mind is that we really have what I would call the factoryization, or that's not really a word, but of medical care delivery. It's become industrialized in the same way that other work did, and it's become compartmentalized, and it becomes sort of a cubicle mentality. I mean, actually, there's a moral aspect of that, which is the less control we have over things, the less we expect of ourselves, and the healthcare ethos has changed. As the quality of care has gone down, the ethos of healthcare has gone down, and it's a vicious cycle because nobody wants to be responsible for everything that's wrong. And for that matter, who wants to fight every day, in their job? So, yeah. Well, I do too, but I'm just look what's become of me. I'm just a hot, sweaty mess, and day after day after day. I mean, you cause a lot of distress for yourself, and in many workplaces, and certainly in healthcare, if you want to get along, you got to go along. Okay.
You pass that to Maxine. So Maxine, can you talk a little bit then, if you are a CNA and you have a physician who's prescribing a drug for somebody and you think there are less intrusive ways to treat what you're seeing, what the behavior is that you're seeing, what do you do as a CNA?
Okay, so as a CNA, And we have now empowered our CNAs to do this. They have a voice. And they literally are the voices of these residents, many of whom don't have families to represent them. So our facility introduces a culture where everyone is heard. So the doctors do listen to us, listen to the CNAs, and I've seen where they have been heard. So here on, we have moved forward into putting interventions in place that are non-medical, and moving forward, we are now in the mode where we are introducing comfort matters to numerous units. We have 3 comfort matters accredited units, so that's where we have gone on. Okay, so comfort matters is what we are now doing for residents with dementia versus psychotropic medication. It's all about comfort. These, what they call behaviors, are just signs and symptoms of distress, and that's what we have re-educated. It's all about re-educating our team, our staff, the family members. Like you said, many of them came into the nursing home on psychotropic drugs, and they said, oh, this is what we say. We are a psychotropic drug-free unit. So here, our goal is to bring comfort. Why is the resident, quote unquote, for lack of a better word, behaving that way? They're trying to communicate something, like everyone else has said here. So it's a discomfort that they're trying to communicate, anticipation of needs, and mark you, it's not just one department, it's a whole team. Everyone is involved. And moving forward, the comfort matters. We train them to anticipate the needs, provide the needs. We don't work on schedules because, like I heard someone said before, the resident who you're going to be given a big plate of breakfast in the morning, and she's going to throw that at you. Why did she throw it at you? We get the families involved. We have to get the family involved. And so they all have a care plan. It's a personalized care plan that is called About Me. The families do tell us what this resident was before they had dementia. And just like you said, they do still have some of those, whatever they used to do, the activities, they remember. So someone that didn't used to have a 3-course meal breakfast is not going to have it now, so she's going to throw that tray at you. What did she used to have? You get that from the family. She used to have coffee, so give her the coffee. So it's all a team effort that includes the family. So you ask, what if the person doesn't have family? This is where it calls for a lot of observation. We are now their family.
Thank you, that's very helpful. Bethany, can I ask you something? I was struck, I've read your report many times. I'm struck by how you got people to be so honest. If any of you, I mean, there's just striking admissions throughout this report, and admissions, as we would say, against their own interest, very much so. How did you guys accomplish that?
It was a monumental task. We talk about how we went to 109 nursing facilities throughout this process. I don't talk about the fact that we got kicked out of or turned away from at least 25 others. This was really difficult research to do because the people whose rights are being violated are asleep in a bed. There are very few people that can talk about it when they're in that sort of a state. So it was really a matter of finding residents, ideally, that wanted to talk to us, talking with family members who were there visiting people, and then talking with directors of nursing, talking with staff members, CNAs, pharmacists, as many voices as we could gather, we gathered. I think that a lot of the admissions against their own interest came from a place of just not knowing. We had conversations with directors of nursing who said, "Oh, informed consent, we don't do that. No, we don't do that in our facility. Maybe sometimes we'll call a family member after we've started someone on a drug and just let them know." just the lack of and it goes to your point about culture. It goes to a lot of what we're saying about whether we're treating people as humans, as people. But just as much as there are these doctors and nurses who are willing to talk about what they're doing so matter-of-factly, we also talked with family members and older people themselves whose rights are being violated, and it's their voices that are always at the center of the work that we do, and that's what has power. With those voices, you know, I think about what the family members and what the residents that we were able to talk to wanted. And I think of this one woman, Carla, in Kansas, and you can see her in the video, but her mom was put in a facility where she was put on antipsychotic medication. And her mom didn't know it, she didn't know it. And we ran into her in the hallway in a facility. We started talking with her. We got a nurse to come in and look at him, along with an ombudsman, and looked at her mom's medical records and realized that she was on these antipsychotic drugs. And her daughter, Carla, started working, and she worked for weeks and months until she could find another facility where her mom could be without being on these drugs. And once she got off the drugs, her mom could talk again. Her mom could dance again. And she told us, I got my mom back as much as I could have her back. And her mom got her daughter back as much as she could have her back. That's what we're going for here. That's why we need to get people off of these drugs.
Thank you. I'm struck by, I mentioned the Ventura County class action that we had, and we built the class action around a doctor who, under deposition, said, I have never, ever gotten informed consent for any of my patients. How could I? I have 200 patients. How could I possibly get around all those facilities if I was doing informed consent on top of prescribing? So we were like, class action, you're the center of it. Everybody who's ever been your patient is now a member of our class. But I mean, this is the cultural problem, is that it's so shocking to us and so commonplace to him that is how he operated for decades. So Lori, on the ombudsman piece, so going to the frankness of people in the facility, do the ombudsman, how do the ombudsman interact with that sort of frankness in the facility, and how can they use that? And how do you train them to use that frankness of the people in the facility to try to find out what's really going on, and how is, what is actually impacting people?
Mm-hmm. Well, as the ombudsmen are in the facilities on a daily and weekly basis across the country, they're talking with people, they're getting to know the residents and their families, and so they do develop relationships with them over time, and many of them are getting frank information. The ombudsman will work on behalf of an individual, a specific individual, with consent of that person or of their legal representative. If they're not able to get consent, or sometimes a resident or family is fearful for having themselves identified, the ombudsman will look in different ways to work and raise those issues in a facility, either by filing a complaint themselves about a particular issue. If they're able to observe it among multiple residents in a facility, they'll maybe work with the resident and family council to raise particular issues and work on it in maybe a more systemic way. But it's important to have that frankness and the relationship building, and it's important for the ombudsman to be in those facilities, which is why we're looking at supporting increased funding for the program so that there could be additional access to the residents and the family members.
Do folks in the audience have questions? I want to welcome anybody that wants to ask the panel. We've got plenty of questions for them, but I just want to make it the option. Sarah?
Hi, I was just wondering.
Is there another mic somewhere? No, we just have the one mic.
This is a question for Maxine. What is unique about your facility and your training that makes yours different from the rest of the stories we're hearing?
Because we've proven that it works. Yeah. So I can say firsthand, we have proven that it works. These residents should not be on and do not have to be on psychotropic medication. It takes the whole team to determine that, and we have proven it through Comfort Matters and a whole lot of teamwork, getting the family involved. So that's what I think does make it different. Firsthand, I've seen it.
So one of the other questions, we were talking about person-centered planning, and one of the things I was hoping you guys could talk about is just simple, like, changes in environment that help to kind of calm a situation. As for Robin's dad, there was just another guy in the facility that they didn't like each other, and so that the facility promised to keep them apart. Seems a very simple solution. They failed to do that, and it resulted in problems for them. So what about, like, those kind of very simple environmental changes?
We talk in our report about a particular quote from a director of nursing who voluntarily worked over the course of about a year to get all of the residents in that particular facility off of antipsychotic drugs. And he said that there was a lot of resistance at first to this process. The staff thought that it was going to be mayhem, and instead it made the staff lives and jobs much easier, because people could ambulate, people could eat their own food, people could at least communicate that something was wrong when something was wrong. But what he also said was that they didn't have to increase their staffing of direct care at this particular facility. The only thing that they had to do was add an extra activities coordinator, because now that people were awake, they wanted to do things. So I think that in terms of environment, that's one of the cases that we've heard, and we've heard that echoed with other directors of nursing as well.
Excuse me. So I think activities is a really important addition to an environment, as well as really paying attention and knowing the residents and what their interests are is a second one. Because we hear stories all the time about people who start walking at night, for example, in the halls, and one of the reasons they do that is because their entire life they were a night watchman who that was their habit. So learning people's habits and helping to reinforce those as much as possible in a safe way when they're in the nursing home. But the other thing that was always telling to me when I would go and visit my grandmother in a nursing home was the way care is provided to the individuals. So, and Jonathan referenced it in his presentation earlier. If you're coming at someone with a brush and are being aggressive and brushing their hair, you put your hands up to defend yourself. But if you're gentle in the way you respond to someone and the way you're providing care, like I don't know how many times I would watch a staff person go to brush someone's teeth, and instead of like talking to them or helping them hold the toothbrush, they would like just shove that toothbrush in their mouth, or if they were feeding them, shove a spoon in their mouth. And it was very rough and aggressive. And so really in the way we train staff, teaching them to be calm and gentle with people, I think is an environmental change that goes a long way in helping to reduce that defensive posture.
Yeah, if I could just add a couple things. I want to talk about this on more of a macro level for a moment. A lot of what the issues we're talking about are really mismatches between what people need and what they're getting. And the way that the medical care in this country and healthcare is organized in this industrial way is really, if you look at hospitals and medical centers, they're designed for the efficiency and the maximum benefit of the people working there, not the people living there. And this whole idea about person-centered care really is an effort to try to shift the power to people receiving the care, which you can imagine is resisted for a lot of reasons. And I want to tell you this quick story. I've had this conversation with several people, from the board of trustees of the American Medical Association to a vice president at Johns Hopkins to the chief of staff at the University of Virginia, and various hospitals and do studies to figure out why do people choose our hospital versus another, or why don't they choose us. And I've heard this statement made from the podium from with audiences of thousands of doctors, and it's always the same answer and it presented in the same way. They always say, you know what the number one reason is people would choose some other hospital instead of Johns Hopkins? Parking. How can our patients be so stupid? What idiots, our customers are idiots. And I'm like, you don't know anything about the care of older people or the care of people, because if you can't access care, it doesn't matter how good you are. And you're talking about places that were not designed for the people that need the care there. We have this complaint-based system where you have to have a complaint or you don't get any care. But if you complain too much, anyway, but when you look at specifically how care is organized, if you seek health care, if you're in a hospital or a nursing home, you heard about the number of, it's often referred to as PPD, hours per person per day that you talked about. How did they come up with that? Well, they came up with that in the 1990s with companies like Arthur Andersen, consulting companies that figured out, what you're really doing is performing tasks. So we're gonna do these time motion studies and figure out how long does it take to give a bath? How long does it take, to pass meds and so forth? And the idea is that all of healthcare is simply the aggregate of these discrete tasks, which are organized around the convenience and the efficiency of the providers. But it requires people ask for stuff, and it requires them to wait for it, okay? And so where that's particularly problematic with people with dementia also is, and I'm using the example of a child care center, is what's missing in that model is engagement, okay? And also what's missing in that model is supervision. And so when this really took off in hospitals, the number of deaths in hospitals started to go way up. Avoidable deaths due to things like, falls with injury, but also things like cardiac arrests, okay? Because they had cut staffing down to the point where they had no excess capacity to actually take care of sick people, okay? And so what I'm trying to say is there's a fundamental mismatch between how these services, the provision of services is organized and what people need. And likewise, and there's a lot of coercive pressure to admit people to facilities that can't be taken care of. They don't even have time to figure out, until they don't even bother to figure out what is this person's care needs. Similarly, when do people get admitted to nursing homes? Well, it tends to be weekends because hospitals dump people out on weekends. What is the staffing pattern at a nursing home? It doesn't match the work volume. And so you have all these other things that are going on in the environment that contribute to caregiver stress, that make people in a hurry, that make other people around them anxious. And you're talking about, I guess what I would say to you is if you've ever been in a hospital, it's a scary place, okay? And you're expected to sort of overcome your fear, the things that you've been taught. Don't let people undress you that you don't know and you don't like, and so don't let people give you things that you're expected to suspend all of that. Whereas with people with dementia, that's all that's left, okay? And so and it would be really shameful to force somebody who's who's been taught never to let some stranger undress you, to force them to be undressed, especially with other people watching. So the environmental, the more basic things like noise, people being paged overhead, but also just the idea of putting people together in a room, roommates, that's not natural for most adults in this country.
That's a good point. So Maxine, could you answer, in your facility, do you have single rooms, and how do you deal with all the very kind of institutional elements of a nursing facility?
Okay, so yes, we do have single rooms. Unfortunately, not a lot. The numbers that we have there for residents who really cannot cohort. And so it takes a lot of observation to reach a point to know that this person cannot have a roommate. So thankfully we have 3 units that we can work between, and if we don't have a single room on this on this floor, we can take them to another floor. And yes, we do a lot of changes. Like you said, people they're not gonna always agree, the roommates. So it's, as I said, it's a team effort, staff effort. You notice that this person, they're fighting, arguing once they're in the room. What is going on? Oh, you see that she likes to sit with this person at the table. Maybe we could try and have a room with that person. So these are some of the things that we have done.
So another case that Jonathan and I have worked on is a patient dumping case where facilities have dumped out nursing facility resident basically in a lieu of drugging her. So it's same behavior, different side of the same coin. And so I wonder, Bethany, if you heard about patient dumping issues when you were doing your review?
Sure, absolutely. When we look at the pressure that a nursing facility uses to try to get people to agree to use these drugs, they say, if you don't allow your parent to be on this drug, if you don't accept this drug, we can't take care of you anymore. You're going to need to find another place to go. And that's a threat. There are all sorts of reasons why that is wrong. But that, in terms of informed consent, that sort of negates any sort of consent that a person could have if they have it hanging over their head that they're not going to have a place to sleep at night, not going to have anybody to take care of them if they don't agree to be on these drugs. I'm glad you brought that up.
So now I'm going to change gears to be positive. And so try to think about what, and all of us, I challenge all of us to think about how do we go from here? You know, we all feel empowered and outraged and you know, want to figure out how to correct these ills. There are some of them obviously are going to be harder to correct than others, but I do feel like there's a piece of this is that you know, I have incredibly intelligent clients, and my clients didn't know that this was a problem for their parents. So I feel like there's a lot of information gaps out in the world, just even to identify this as an issue for people. Actually, Jonathan and I both trained the whole state of Washington's ombudsman. And literally people started crying when we told them about this. We're like, we are so overwhelmed already. You expect us to now take on fighting against antipsychotic drugs in addition to all the other things we have to deal with? So I really think there's got to be some, let's just put our heads together and think of what are some of the things that we can do from this day forward as a group of committed citizens, and you know, what are some of your ideas?
Well, and we've talked about this before, Kelly, but I do really think that raising awareness among family members and residents about their rights, about these drugs, about alternative treatments, that will go a long way in terms of having questions asked about demanding change at the facility level, and not that we put it all on the families, but you know, as advocates we can provide support to them, but I think that the families and residents really need to be educated about what is going on and what their rights and alternatives are.
I'm going to walk this over to the back. We have a suggestion.
Hi, thanks. I'm just going to say that I think you have a lot of common cause, too, in terms of positive approaches going forward. You have common cause with other folks who I think are concerned about similar issues, but for broader populations. I think this is an issue which is not limited to people with dementia, right? I mean, I think in terms of, say, litigation strategies, it might be you have the strongest litigation strategy to focus on people with dementia where the use of these drugs is contraindicated, but even for the people for whom the drugs are not contraindicated, the people for whom these drugs were designed. I mean, there's overuse of these drugs. There's everything that you've talked about in terms of a lack of person-centered planning, person-centered treatment, not treating people like human beings, not understanding and listening to people, understanding the motivations for the behaviors, not understanding sort of what the person needs and wants, actually. I mean, all of that is true for people with mental illnesses in these facilities as well. And so I think, you know, certainly it's a broader issue than simply for folks with dementia.
Thank you, Jennifer. That's Jennifer Mathis from Basilan. That's why we brought you here.
Hi, I'm Toby Edelman with the Center for Medicare Advocacy. One of the things that I think might bring some more public attention is possibly having a congressional hearing. I don't think there's been a hearing since November 2011, which was focused on the Inspector General's report showing the vast percentage of antipsychotic drug use was totally inappropriate. Jonathan and I got to testify at that hearing, but I don't think Congress has done anything since. And the new, Bethany, your report, Human Rights Watch report, is important. And I think the only thing that Congress cares about really is saving money. So if we could have some of the positive research that Sarah talked about, that if you do this, it will save money. I think, Jonathan, you spoke at one of the partnership calls about Life Care Centers of America realizing that if they cut antipsychotic drugs for their Part A residents, they would save money, and they did. And that's what people care about, is saving money, unfortunately. That's not our motivation, but it's other people's motivation. I think the report is could be a real basis for having a new hearing, and we should try to do that, maybe after the midterms.
I think that's a great idea. I think the other piece of that, though, is kind of combining what Jennifer said too, is that what we need to do is be pushing for non-drug treatments for people with mental illness and for people with dementia, because there's this proliferation, this ubiquitousness of these drugs, and it's the result of really effective off-label promotion schemes, but it has worked, and so now these drugs are actually very, very common.
Again, Kurt Decker with NDRN, and picking up what Jennifer said, there are a lot of other people in those nursing homes. There's people with physical disabilities. Texas has children in nursing homes. And so I think having that kind of a comprehensive approach to who's in those nursing homes and looking at those issues. And we certainly brought PASSAR cases to try to prevent people with mental illness going into facilities. I certainly applaud all of the research, policies, hearings. You know me, you got to be there. You got to be there every day. And the long-term care ombudsman, collaborating with the Protection Advocacy Program, we won't be there every day, but being there and challenging what's going on there is, I think, the only way you really get through that kind of thing. And ACL has done some work in trying to get their two programs, the long-term care ombudsman and the Protection Advocacy System, together in a collaborative way. I always say, I don't want to be passing them in the hall in a nursing home, and I don't want neither of us to be at another nursing home. So we've got to figure out how we triage and collaborate to use our limited resources to get as much coverage as possible and challenge this issue as well as all the other issues in nursing homes.
I think Janice behind you has.
I did. Hi, thank you. Janice Dabney. I work for the Training and Employment Funds in New York City of 1199 SCIU, and I have the pleasure of working with Maxine. I want to connect this to the whole workforce crisis that we are in, and it's only going to get worse. What we're hearing across the turnover rate of direct care staff in New York City nursing homes is quite low. I would suggest that's because there's a union, but let's put that aside for 1 minute. Across the country, we know that the turnover rates are outrageous, and they're only going to get worse. Owners, administrators, people we talk to and we hear from. It's hard to recruit. It's harder to retain people who work in nursing homes. So, to look at the quality of why work there? What makes you feel good about if you're a direct care or a social worker or a geriatrician or a nurse? Why would you want to work in a nursing home? I think that we can connect this because we've so far talked about the impacts on the patients. We've talked about families. I'd like to hear a little bit more. I know I'm kind of leading Maxine a little bit here, but what's different about working on a unit where they've implemented some of these not so innovative, because they've been around a long time, of these things? What's the data about turnover, sick time, et cetera, et cetera?
So actually, the data is, since we have implemented the comfort care measure, we're basically overstaffed. Everyone wants to work on those units. They don't get scratches anymore. Yes. There are no more scratches. You don't have angry families because the residents are falling. You don't have a bored unit anymore because residents are getting up and they're dancing and they're participating in recreational activities. So that's why, that's the difference that it makes, the approach that we have taken in Isabella. That's, the turnover rate. The CNAs are not calling out sick anymore. They basically, they're asking, if you hear a call, do you want to work overtime on my unit? yes, okay, I'll take it. So that is the difference that I've seen so far.
Can I ask you, do you have a behavioral psychologist or anybody that you consult with to try to figure out how to build plans that are personalized?
Oh, yes. We have great psychologists, and they're just adorable. Yes, I know it's my facility, but it's the truth. And we've had cases where we have consulted. We come on the team, we huddle, we say, what can we do for this resident? And everyone's input comes to get a detailed care plan that we share with the family. Of course, the family is involved initially, and it works out. So, yes.
Lori? Oh, sorry.
I just have a really short comment to make, and then I'll pass it over to Jonathan. I just want to say that every resident in a nursing home has the right to care like that, not just the ones that live on this comfort unit. Every single resident has the right by federal law to have a multidisciplinary team, help develop a care plan in participation with the resident and the family member, to have their needs and preferences and wishes honored. Every single resident, and that's what we're fighting for.
Yeah, exactly.
For 30 years, and this is not new.
Yeah.
Well, I would like to say a few positive things before the feeling passes, okay?
Quick!
And I will start with the issue of turnover, which most people would not say is a positive thing. It's very detrimental, and I won't say more about how bad it is, except that when you look at what happens to people who, CNAs, for example, or nurses that leave a nursing home, what happens to them? They go to another one and another one. And now you might say, well, that's just a bad penny that, that you can't get rid of. But here's what I choose to believe. I choose to believe that because I work with them, that they're searching. They're searching for a place where their values are shared by the workplace, where they can carry out their mission. Okay. Oh, probably not.
There you go.
I was probably snorting. So they're searching for a place. They're trying to do their life's work. I mean, I like to say we don't choose our work. This is true of everybody in this room. We don't choose our work. It chooses us. It's part of who we are, and we're trying to, carry out our life's mission through our work. And so often, the job gets in the way of the work. Now, the example I gave of being fired by folks, and that happens to me all the time. But put it this way. Imagine if I'm the nurse or another caregiver, and I believe that, hey, this guy's he's got the power to fix this, and he won't do it, okay? It's very demoralizing and so forth. So in contrast, and I'm going to talk about Maxine for a second. Maxine is a leader, okay? And one of the primary responsibilities of leadership is to say the status quo is never an option, okay? Management is all about maintaining the status quo, but leadership is all about change. And you have to have somebody who's in a position of some power in an organization, but also who has the credibility, who other people, we choose our leaders, we don't choose our bosses, okay? And so, she's a leader because other people choose to follow her, and she makes it safe for them to change their behavior. Okay, and the thing is, what they get, they're empowered. Now they have the tools. Now they have the solution to the problems that I wouldn't give to them in the past. So ultimately, that's how this kind of change happens, and I've seen it happen over and over again. Only to be, but when turnover happens and other things that can undermine that. But I just don't want to. We all make a difference. If I thought about the kind of difference I made every day, I'd be afraid to leave the house because I'd be worried about what I just said last week or last hour or something like that. But we, and constant dripping wears away the stone. So, doing nothing and just accepting the way things are, that's just not an option. And I do believe that this can change, but it's going to take lots and lots of different things. Now, on a macro level, how do we deal with big issues in healthcare where something's dangerous? We make it harder to do that, either by regulation or more often, particularly with drugs, insurance companies say, well, you have to have a prior authorization or something that's very expensive. They make it harder to spend that money. And so if you compare it to opioids right now, every insurance company in the country, including CMS, is talking about limiting the use of opioids, including how many pills can be dispensed. If you really want to make this problem go away tomorrow, as far as these drugs are concerned, just have work with insurance companies to basically give them permission to not pay for things that they shouldn't be paying for. That said, you're not going to solve the other problems, but stopping the medicines doesn't make it worse because they don't work anyway. It removes that distraction.
I want to say something on the positive side too. I think we've mentioned here a couple of times the demographics, the baby boomers, how many people are over a certain age, and I think that we should use that to our advantage. So we have a large population of people who want to hear about this because it could be them, could be their parents, right? So we need to use that to our advantage and do like a public service announcement. I mean, we think about the campaign against smoking, and there are all these public service announcements about how it's bad for your health, and it reduced smoking dramatically. I'm thinking about something along those terms, really reaching a broad range of people to let them know what the issues are. And this is sort of intuitive. We're all sitting here going, oh, I wouldn't want that to happen to me. Yes, I would want, you know, it's intuitive. So why not take advantage of that and really, really get the word out in a massive way?
All right, so there's another question from Elizabeth in the back. And Elizabeth Prior in the back.
I'm sorry to ask so many questions. It's a disease. I was curious when I think it was Bethany, when you were talking about how CMS has actually decreased requirements for, or decreased the level of fines. And in my mind, I'm just thinking, why would CMS do that? And I imagine that it's connected to the provider shortage issue, where they say, well, you know, it's so hard to find providers, let's just use chemical restraints. I mean, or it could be maybe it was done by Trump and he hates regulations, I don't know. But I keep thinking about the provider shortage issue. I've read AARP's report on it. Anchor did an amazing report on it. And I haven't heard the term comfort care. And yet you guys are the leaders. And so where am I missing it? Why has it not been raised in that context? Now I want to shout to the world. I'd never even heard the term, and as I said, I do read, you know, about provider shortage issues.
Well, I would hasten to say there's no provider shortage with nursing facilities. And I think that there are, you know, the occupancy rates in nursing facilities are still, there's still beds available for people. I think there are maybe some, but not all nursing home facilities are created equal. And so I think that there are problems for people across the country identifying good services, particularly for people who have dementia. And I think people get turned away all the time because they have dementia. And I think that that's part of the struggle that we're having. I'm thrilled to learn more about the comfort homes and to find out more about how we can sort of champion those things and get the word out to more people, because I think that's really what we need to focus on.
With regard to the specific issue about the regulatory enforcement, there's a history that I'll just tell you about very briefly, which is when these regulations first came about, there was, and the irony in all this is it was the Institute of Medicine that came up with these recommendations, but it's been doctors and medicine that have fought them hard. And so this has been a power issue. And one of the ways that the workarounds or the gaming the system that happened with regard to these medicines was, and it really created an industry in and of itself, was to essentially facilities decided, well, we'll just get a psychiatrist to give us permission to use this medicine. And which resulted in an industry whereby facilities actually pay psychiatrists to be on retainer to show up and then bill Medicare for visits and so forth. And so you have the surveyors who are not physicians basically being browbeaten by somebody saying, well, you're not going to tell me how to practice medicine, and AMA and others basically saying, you're not going to, we don't want government intrusion in medical decision making. And that's been the real resistance to enforcing these regulations in the way that they ought to be. And some of that is very subtle, and it's just, but that's the history.
Jonathan, would you give Bethany the last word?
Wow, the last word. Thank you. That point about a shortage, I think, is something that I've heard about in conversations with lawmakers who say, but what if the facilities threaten to close if we actually regulate them and enforce their mandatory requirements? And it's something that they've been threatening to do for a long time. I don't know about a shortage. What I do know about is that it is choice. People should be able to live where they choose to live. So if baby boomers are going to be are going to be aging in America and are seeing how their parents are being treated and don't want it to be that way for them, they probably want to live in the community. That's what I hear over and over again. Oh, nursing homes, I'm not going to go there. I saw what happened to my mother. I saw what happened to my grandmother. That's not how I want to live out my days. Well, if that's not how we want to live out our days, we need to be working to change it. And having more community-based services available for people that choose to live there is a really important aspect of making sure that people can have that choice. So it didn't come up much in our conversation this morning, but I thought it was an important point.
I appreciate you raising that. That's a good final note. Thank you guys for coming.